Next, Dr. Grover will be speaking on upper lid retraction.
Thank you, Dr. Ritchie, for making me a part of this nice session. So I'll be speaking on management of eyelid retraction. The surgical management of eyelid retraction is very commonly a part of thyroid eye disease, where you follow the sequence of taking care of first the orbital decompression to get the globe in right position, then taking care of the motility, and the eyelid surgery is the final consequence. So an example is this, where we take care of proptosis first before going on to eyelid retraction correction. What are the surgical objectives when you want to correct an eyelid retraction? You want to abolish the scleral show, which may be disfiguring like you see here, and production of a normal eyelid contour is important because many of these cases have a temporal flare. What is important is that the eyelid crease can often get recessed when you do this surgery. So you try and maintain the eyelid crease as best as possible, and in unilateral or bilateral cases, getting asymmetry is also again a major issue because eyelid retraction is probably less predictable than ptosis surgery and needs that much more precision if you can, but at least try your best with your experience to try and get the results as symmetrical as possible by on the table assessments. So essential principles are weakening of the levator complex, where you can excise the Miller's, which is lifting up the eyelid, and you may need to combine it with levator weakening or giving a incision through the eyelid or blepharotomy. The other principle is that you lengthen the levator itself. You don't just recess because that often tends to reverse back. So you need to lengthen it by putting in a spacer as well, or you can just do myotomy at both the ends in order to get a recession or lengthening. So let's look at the approaches that are used. This is the conjunctival approach, where you are dissecting the Miller's muscle away and excising it, or the anterior approach, transcutaneous, which we are using in a blepharotomy or a spacer. So what procedure do you choose? Choice of surgical procedure for mild cases up to 2 millimeters is usually mullerectomy, but sometimes for contour correction you may need a levator tenotomy as well. In moderate cases, you need to often combine mullerectomy with levator recession or tenotomy, or a blepharotomy is then the procedure of choice in the severer grades of up to about 4 millimeters or more. And if it is more than 4 millimeters, then blepharotomy is possibly one choice, but in very severe cases, spacers possibly become integral to the procedure. A number of spacer materials have been used, but the ones that I have used commonly include hard pallet and autologous sclera. So we'll see a video with a scleral thing, but let's go on to mullerectomy. So first thing is to try and create a plane between the conjunctiva and Miller's and the tarsal Miller's and the levator. So this is the incision at the upper border of tarsus, and then you create a plane first between the Miller's and the levator by dissection, and an assistant holding the edge of conjunctiva or sutures, as you will see in the next video, may be a good option, and then you create that plane between the Miller's muscle and the conjunctiva and dissect it. You can do it in one go, or you can do it in two halves as you are seeing here. Create that plane with your dissection, dissect away all the Miller's muscle for a height of up to generally about 8 millimeters. Severer cases may do a little more, and you excise it all the way up to the upper border of the conjunctiva. And then you may or may not combine it with levator tenotomy. You may use a 80 vehicle for closure, making sure you take small bites so that you don't cause an exposure, suture keratopathy. Here we are lifting off conjunctiva a little bit with forceps to create that plane of cleavage, using sutures for the retraction or holding of the conjunctiva, and then dissecting again between Miller's and the levator complex, as you see here. So this was a little severer, where we are planning a combined procedure.
Sir, please continue, sir.
Thank you.
ये हटा दीजिए, please.
So this is the dissection that continues between the plane between the Miller's and the conjunctiva. That dissection is completed, and the fibers of Miller's are excised. But then you need to correct in the severer cases, not just the temporal flare that many of these cases have, and you do an on-the-table assessment. Many of them may need a further weakening of the levator by dissecting those fibers, and on-the-table assessment tells you that you probably need to do more for the temporal flare, and we are doing that. Till you are satisfied with the correction and contour, a little over-correction on the table with a little ptosis creation is essential, and then you can suture with either the technique of 80 vehicle that you saw, or we sometimes use a 6/0 nylon suture starting from the skin end, coming out at the skin end with small bites. So examples are a moderate lid retraction where we have corrected, this is the moderate retraction that you see here. It's about 3 millimeters, 3.5 millimeters, and this is the post-op result after Müllerectomy and levator tenotomy in up gaze, down gaze. So full thickness blepharotomy is the procedure for the more severe cases. Anywhere between 3 and 5, I would probably go ahead with full thickness blepharotomy. So we've given an incision in the skin crease line, dissected first the orbicularis, then go through the structures, dissect between the levator and the conjunctiva Miller's complex, lifting up the entire lot of levator, possibly with Miller's, and then excise it from its attachment onto the tarsal surface. We're dissecting this away, and then you need to assess what the correction that you wanted, whether it has been achieved or not, and once you decide that you need a greater correction, then you would probably go ahead with incision of the conjunctiva full thickness on either sides, leaving a central pillar of about 5 millimeters to maintain the shape and the contour. So this is, we've done a blepharotomy on one side, but this is a matter of titration. So this is what is very important, that you do not over or underdo it. So here we've done nearly a full thickness blepharotomy. We are assessing whether this will do till we get the right correction and the contour. So this was a patient with proptosis and lid retraction, where we've done a blepharotomy. This is an early post-op picture with correction. So this was a patient who had a ptosis surgery done, was an acquired ptosis, and ended up with a gross overcorrection done by a non-regular oculoplastic surgeon. So this was ended up with a retraction which was almost 6 millimeters, and he was a very suicidal patient who forced us to do his surgery. So we went ahead and did a correction with a scleral graft. Unfortunately, I think we saved a life by getting his correction right. Remember this patient? Okay, so you have to space, you have to have the spacer, which is, this was a scleral graft, which is about 1.5 to 2 times larger than the correction that you require, and it has to be shaped well, it has to be attached to the tarsus, and it has to be attached superiorly to the recessed edges of the levator, and then again assessment, and then closure of the skin muscle. So this is an example of a transconjunctival orbital decompression for cosmetic indication, followed by a blepharotomy for correction of the eyelid retraction. We'll skip the lower eyelid retraction, hard palate graft, and stage procedures. As we said, you first do a decompression, followed by a hard palate graft for correction of these cases. Thank you very much. Thank you again.
Thank you, sir, for this wonderful presentation. Just, sir, to add, we do get patients who in active TED, they are advised eyelid retraction surgery, so that the message should be that no intervention during the active phase of TED. So that is one thing. Sir,
So
do you
not
use,
just the systemic part of it needs to be well controlled,
yes,
but at the same time you have to make sure that stability has been achieved. So we don't normally would give about 6 months to ensure that everything on systemic and the ocular front is stable.
so do you use silicone bands ever for upper lid retraction? I've used, they have good results.
I used them for entropion correction long time ago for those when I was in GNEC. When that time the maximum cases we used to do was failed entropions where they had lost their tarsus. So as a tarsal support I had used them, but then I realized it is too thin a structure to have a silicone band there.
No, sir,
And
I'm
I
talking
had
about
to,
the
yeah,
upper lid.
maybe at that time हम अनाड़ी भी थे तब
Upper lid के लिए, sir.
शुरू कर रहे थे oculoplastic career. So some of them got exposed also. So thereafter I have not used a material like silicone in upper lid. I would much rather use a hard palate graft or something.
Yeah.